work in progress. I'm really delighted to be here today and presenting to you work that we've been basically developing over the last, hard to say really, 5 years anyway, and sort of where we've reached with all of that. So the title of the talk is Engaging Street-Involved Youth in HIV Interventions. And it actually covers a whole bunch of different studies, okay? So I'm not sure if you can see the slides yet. Yes, I think you can. Great. All right. If at any point you don't see the slides anymore or something, please interrupt me, okay? Oh, I think I forgot to turn my video off. Sorry. No, I did. Okay. All right. So, so first of all, just a little bit of context. You know, I think anybody who has spent any time in sub-Saharan Africa, or for that matter, North Africa or Asia or Latin America, or even Canada and the US, right? We have a lot of street-involved youth. And what we have a lot of as well in sub-Saharan Africa, at least, and many other, materially deprived areas of the world are street children. And so it was very jarring for, I think it is very jarring, I think, for most people when they see this for the first time. And, it really kind of caused myself and many others, Professor Ayuku, for example, who's been working with this population for over 20 years, to try and see if we could understand something about them and try and see if we could do something for them, about them, with them. And so, of course, we started with the literature. And what we found is that there are really 3 major categories in which the literature falls concerning street youth, particularly in low resource settings. The first is about substance use, which we summarized that literature in a systematic review and meta-analysis and published it back in 2013. There's a systematic review, not a meta-analysis, on the health issues in general of street youth in low and middle income countries, published in 2013 as well by Woen and colleagues. And then the other big chunk of literature out there is about the causes of street involvement, which again, we summarized and published in 2016 through a meta-analysis and systematic review. The gray literature, like if you look at UNICEF literature, Save the Children, and so on, they talk about street children and street involved youth in the tens to the hundreds of millions, right? They're very hard to count. It's a very hard problem to quantify. And excuse me. And they're really just, there's not really that much that's known about them, right? And they're hard to engage. So we thought, okay, well, how do we really tackle this, And we decided to try and take a pretty typical public and population health approach that the World Health Organization published as part of its smoking, violence prevention campaign, but that really, is a great model for trying to address an emerging or critical public population health problem, okay? And so we started with surveillance, okay, and defining what is the problem, identify the risks and the protective factors and understand the causes, develop and evaluate interventions and figure out, well, what works and for whom, and then to try and scale up effective policy and programs through implementation. So in terms of surveillance, one major problem is substance use, which is very, very common, and it's predominantly the inhalation of volatile solvents, which in the case here is basically shoe glue. It's legal, it's really cheap, and a little bit lasts a long time. Unfortunately, it really fries your brain. And So, but this is the major thing that kids use in addition to alcohol and marijuana, but really the glue sniffing is the dominant issue. Part of the problem is that they have serious sexual and reproductive health challenges. They experience a lot of violence, and all of this leads to a very high prevalence and incidence of HIV, sexually transmitted infections, gender-based violence, and other kinds of violence, and of course, child abuse and neglect. We've been able to identify that there are a lot of deaths occurring in this population, and most of them are preventable. They're all premature. I'm going to talk about that a little more in a minute. And then there's the issue of what I think of as the survival imperative. All right, so their basic needs are core to, obviously, to their lives, and meeting their basic needs is like their primary concern pretty much every day. Just getting enough to eat, getting something to eat, having somewhere to sleep, that kind of thing. So I just really want to take an opportunity here to drive home the issue of HIV acquisition among street youth specifically, okay? So this is data that was just published a couple of weeks ago, and it compares HIV incidence among orphaned and separated children in the Oscar cohort living in family-based settings and charitable children's institutions, so orphanages and rescue centers, and street youth. And what you can see immediately, okay, from this Kaplan-Meier graph is that street youth are much more likely to acquire HIV over time, okay? They're also much more likely to die over time. And in unadjusted analyses, these are statistically significant, but even in adjusted analysis, adjusting for gender and baseline age and so on, you can see that for street youth, compared to orphans and separated children living in a family-based setting, all right, the adjusted hazard ratio for acquiring HIV is 17.3. And even if you just stick with the lower bounds, right, they're still at least six times more likely to acquire HIV than even other orphans and separated children living with extended families. And orphans and separated children in the community generally are they're at least double the risk of HIV, compared to non-orphans. So even compared to another high-risk population, HIV is a really, really serious issue for this population. So the next step is to try and understand, well, what are the causes of these problems, right? And it depends what you're talking about. The dominant causes of homelessness, for example, among them is extreme poverty, family conflict, and child abuse. And these are the three primary drivers of children and youth to the street, actually all over the world, and including in sub-Saharan Africa. The causes of substance use really kind of come down to, just the basics of being on the street. So it's most frequently used as a coping strategy against the hunger, the cold, the fear, to have a sense of belonging with their peers. And it's also a part of the initiation practices of young men and boys, especially onto the street. And, so they're sort of forced into getting started. And then, in fact, glue and volatile solvents can be quite addictive. And so then they get hooked, and then it's, it just carries on. The causes of sexual and reproductive ill health and violence include like a number of proximal factors or things that are kind of immediate to them. Lack of choice, for example, survival imperative. That kind of is similar to saying lack of choice. They do what they have to do to survive. And then there's poor availability of services and support for them, and both in facilities and in the community. And so that makes it very difficult for them to get, for example, PrEP and STI screening and all these kinds of things, okay? And then there's a lack of knowledge about how to protect themselves, and a lot of myths and misconceptions about HIV and condoms and gender issues. But then in the bigger picture, right, there are these kind of distal causes, which are, much bigger, much broader, more historical, and fundamentally come down to patriarchy, colonialism, and capitalism that create this sort of social structure that gets reproduced in the subculture of street youth. And so it's quite complicated. And then the major causes of death are actually HIV and violence or assault. So for the girls and the women, HIV is represents 2/3 of the causes of death among them. And among the boys, it's predominantly violence and assault, but it's actually very closely tied with HIV, even among the males. So, you take all of this and you think, my God, where to start? These issues for this population are so challenging and so complex, and so kind of deeply rooted, right? That it's really hard to know where to start. And it's clear that there are going to be no simple solutions to the problems facing them, right? Like, for example, to get children off of the street, well, okay, that means fixing extreme poverty and fixing family conflict and eliminating child abuse. I mean, these are big problems, not just in Kenya, but everywhere, right? Everywhere. So, I've been doing HIV work for a long time, and I thought, well, we could at least try and prevent them from getting HIV and dying from it, if they do get it. And so basically that's where we just started to start. And so just moving on then, and if you think of that, diagram, the WHO diagram that I showed you, so we started to ask the question of, well, what are the best HIV prevention and treatment interventions for them? At this point, there are a lot of evidence-based interventions. We weren't sure if we needed new ones or what. So we again went back to the literature, dug into it, and used a very systematic, a 5-stage approach for trying to identify, relevant interventions. And so the goal of this was basically to identify these effective evidence-based interventions for HIV prevention, testing, or care for high-risk youth that may be suitable and could be adapted for street youth in Kenya. So, we searched the literature using a combination of pretty broad search terms. We selected a bunch of studies that we ended up actually only choosing to review reviews, okay, systematic reviews and scoping reviews of existing interventions, because there was so much literature out there. Indeed, there were 20 rigorous systematic reviews basically on this question. So we did essentially a review of the reviews. And we extracted all the data, put it into Excel, and then put the results together and had some reviewers, knowledgeable about the street youth community, to read them. And then a broader group of stakeholders essentially to come together and have a series of discussions about what kind of potential interventions could be relevant here. So we divided them into behavioral, social, biomedical, and structural. And each intervention was assessed in relation to its potential impact and position in the HIV prevention care continuum, what we felt like would be its feasibility, its applicability, and its suitability to the target setting and the target population. And we came up with the list, and this is basically, excuse me, the list of what we came up with. And then we proceeded to test most, if not all of them. All right, so we started really with Peer Navigators. We did a point in time count to try and estimate the size of the population and the HIV prevalence among them. Voluntary male medical circumcision, offered as part of a 10-day healing educational coming of age initiation process for male street youth. Comprehensive reproductive health services, all right. Basically increase of knowledge and awareness around HIV issues, okay. And so anyway, I'm not going to really talk about this because I want Lonnie Embleton, who really led this work for her dissertation. I want her to present her own work, okay? But it was basically these two different evidence-based educational curricula on HIV prevention that were offered in combination with an innovative match savings intervention. And so she adapted and piloted that. And then the use of incentives, which in our case was the use of modified directly observed treatment. And I will talk about this shortly. And as you can see, so pretty much everything has been published. We're just finalizing the manuscript for this MDOT program now. The only thing that's not really published is the reproductive health services, and I'll come back to that. So, of course, we're Ampath, right? So we lead with care. So that's why we wanted to start with the Peer Navigators, because it was all about connecting street youth with existing interventions, all right? Basically with existing HIV testing services, HIV care and treatment, that kind of thing. And the concept of Peer Navigators in this context actually comes from a very large community-based program of peer navigators for people who are homeless and injection drug users in Canada and British Columbia specifically. And so we initially hired 2 peer navigators, 1 male, 1 female. You can actually see them here. There's John and there's Purity Regina back there. And they're taking this group of street boys for HIV testing. And I love this picture because I think it gives you a really good sense of the kind of chaos that engaging street youth in healthcare services can actually bring. All right. Like, I feel sorry sometimes for the HIV counselors, and they've got this giant gang of young, high boys coming into their office. And, you know, they're rowdy and they're trying to be macho and all of that. It's a real challenge. But our peer navigators have done great, and the HIV testing services has risen to the occasion and is doing great. So our initial peer navigators were of mixed HIV serostatus. We didn't want only to hire people living with HIV because we didn't want to stigmatize them, and we didn't want to stigmatize the program. You know, we wanted them to be safe to be approached by street youth in the community or whatever. And so that was very important. They were literate and numerate, and their goal was to link street youth basically to existing services. And the focus at that point was on youth who were less than 25 years. So we started this in 2015, and then we followed them in an evaluative kind of framework for nearly 3 years, actually. And over that time, there were 781 participants who were engaged at some point by the peer navigators, of whom 63 were living with HIV, including 196 females, or 18.4% of the females, and 4.6% of the males. And remember, these are mostly young people, right? So these HIV prevalences here, first of all, this is a convenient sample, but they're very high. 4.6% is like the average HIV prevalence in Wazingishu, okay, among adults. And this is just among males and among young people, among youth. So this got us a little worried. And what we did was we kind of summarized their outcomes according to the UNAIDS 90-90-90 framework, okay? So for example, we managed to get close to 90% of the street youth engaged by the peer navigators to know their HIV status. We managed to get, the peer navigators managed to get over 80% of those living with HIV initiating ART. And the peer navigators, the street youth, about 38-39% of them, of those who had initiated ART were virally suppressed, okay, by the time that we did the analysis. And so what we realized is that the peer navigators are actually very good at engaging street youth in HIV testing and treatment, but that it wasn't enough to enable street youth to adhere to their treatment on a daily basis. So because the HIV prevalence in that population in the Peer Navigator study was so high, we decided we needed to try to do a more population-based HIV prevalence survey. And so what we did was we kind of built it into something called a point in time count, all right, which is an enumeration method for homeless populations that are very, very commonly used in the US and Canada to count homeless populations. And actually, in many places in the US and actually nationally in Canada, there's, well, pre-COVID, there were annual counts that were being done. And so basically we adapted this, okay? And I just want to quickly mention that in the past, head counts have been the dominant approach to counting street children in low and middle income countries, meaning that you have a team of people, they stand on the corner and they try to identify who are the street children in this area over like these few hours of time and count them. And then they have somebody else doing it somewhere else, and so on and so forth. And then they have a big meeting at the end of this and try to agree on a total number. It's a really unreliable way to count street children because, first of all, it involves stereotyping. Doesn't deal with double counting at all. And yeah, just is not very systematic. So we decided to try this point in time count, and we did it over 1 week in September 2016. Conducted a lot of community mobilization and mapping of where street youth are in advance. We had one stationary and one mobile enumeration team, and each team included enumerators, okay, HIV counselors, social workers, psychosocial counselors, street youth who were instrumental in providing security and making sure that we reached our target population, and healthcare personnel, so that somebody could come, whether they got counted or not, they could, get some basic healthcare out in the community where we were doing the counting, some counseling, an HIV test, all that kind of thing. But most of them agreed to be counted. So they were eligible to be counted if they'd been on the street at least 3/4 of the time for the past 3 months, and they were aged less than 30 years. And we used digital fingerprint technology to prevent double counting, which actually worked quite well. So what you can see here, okay, is like this is a histogram of by age of males and females who we counted. And I think this is an important figure because it shows us at a glance that there's actually a lot of people, a lot of kids who were, young, right? Like under 13, under 15, so on, and including girls and boys. And you can see this kind of summarized here. So 35% of this population, of the 1,419 people aged less than 29 who we counted, were under 15, right? This is like a high priority population for intervention for child protection services, if we had functioning child protection services here. And then about almost half of the population was 15 to 24, and 19% were 25 to 29, were a bit older. And overall, about 26% of the population are girls and women, which, people are always saying, oh, we can't find the girls, we can't find the women. Well, they're there. They're definitely there. So this slide has a lot of data on it, so I'm going to try and keep it simple. So the first thing I want to point out is that we have very, very high proportion of people accepting HIV counseling. And the way we did it was, whether they were HIV positive or HIV negative, we asked everybody to go talk to a counselor, okay, just like that. And then it was at the stage where they're talking to the counselor that they were asked what their HIV status is, so that there weren't people overhearing, right at the outset. And so there was very high uptake of that initial HIV counseling. And we identified 19 people, including 5% girls, who already knew their status. And of those, the majority of the girls, at least 13 of the 14, were in care, and 3 of the 5 boys were in care, which is actually quite good. Okay. So when we look at of those who previously died, who were previously negative or unaware of their status, who accepted testing, again, very high acceptance of HIV testing. There's a chat. Who consented for HIV testing? We had a waiver of consent, Jerry, from IREC and of guardian consent, because I have to go back and check. I think the county children's officer or the district children's officer at the time gave his consent for HIV testing. And the ones who were very little, right, if they had their parents or guardians with them, then they were the ones consenting. So of those who actually got tested, of those who actually got tested, we definitely found some new positives, and including 3.6% of the women and 2% of the men. All right, for an overall HIV prevalence of 4.1%. But what you can immediately see is that there's a big difference in the prevalence between the males and the females. So it's nearly 9% among the females, 2.7% among the males. And this becomes actually starker and starker as the age increases. All right. So among the group who's 15 to 24, 2.8% of the males were HIV positive compared to almost 11% of the women. And among the adults aged 25 to 29, 5.6% of the males were HIV positive, and 26.8% of them of the females were positive. And this figure, I think, really makes the point that there's a relatively stable prevalence that escalates a little bit with time among the men. But among the women, there's like this rapid escalation, right, between the ages of like 18 and 26, 27. And so this age group, right, they are critical to intervene with, probably even from the age of 15, critical to intervene with. They absolutely need HIV testing. They absolutely need access to PrEP. They're virtually all at risk. If they're on the street and they're female, they're virtually all at risk. And they need access to comprehensive reproductive health care. There's probably scope for improving both of those at this point. And this just kind of drives home that the girls and women in the older 2 age groups are several times more likely to be HIV positive compared to the boys. So speaking of boys, voluntary male medical circumcision is an evidence-based HIV prevention intervention. And so we wanted to see how it would work in this particular population of street-involved boys. We targeted 120 of them, and we basically divided them into 3 groups. So we had 116 ultimately in 3 groups, and the whole thing took place over 10 days, where day 1 was consenting and assenting, and bathing, preparation basically. The actual procedure happened on day 2. Days 3 to 5 was all about healing. Days 6 to 9 was all about education. And then day 10 was the big graduation. And although we didn't measure it, we had hoped that this would ultimately reduce HIV incidence, potentially improve HIV knowledge and attitudes, increase resilience and self-esteem. And these are a couple of the scales that we used. And basically what we found is that the VMMC is like highly acceptable to this population. It's highly cost effective, and thanks to Omar Galarraga for doing that cost effectiveness analysis. And there's, really high demand for this among boys, street boys today. I mean, every year there's high demand for circumcision. And of course, the problem is not the procedure, right? The procedure can get done wherever, but it's the healing. They need somewhere safe and clean to heal. And it's an opportunity to try and educate and and build them up, build up their self-esteem, improve their attitudes towards girls and women and gender, and of course, educate them about HIV and stuff like that. So, at this point, we are actively looking for financial support to support annual VMMC campaigns for street-involved males. And it's given that it's such a highly effective intervention for which there's high demand, it seems like one of those low-hanging fruit. And the other thing I want to point out here is in this picture, okay, so these are the graduands, and they look like normal, healthy, well-dressed, well-behaved, well-fed boys, but they're street youth. And 10 days previous, they looked like these poor kids, right? Who are all like one mass of gray. See lots of glue bottles. They're kind of chaotic. But, this for me drives home the point that, it really, it doesn't take much to, to help these kids kind of get their lives together a little bit. And then there's the Comprehensive Reproductive Health Clinic, which I really want to acknowledge Ampath and Professor Kamayo and the Rafiki Clinic for really stepping up to try and make this happen. And so, what we realized is because of the stigma around HIV, to be successful, HIV services have to be embedded in a broader set of health services like reproductive health or mental health or both. And reproductive health, I think, is quite critical to this population for a whole bunch of reasons that I think are probably evident to most people at this point. And so we were very fortunate that there was a street youth module of the Rafiki Clinic that was established. It was intended to provide kind of comprehensive reproductive health, including HIV testing and treatment. And, it sort of worked a little bit up and down. There were a lot of implementation challenges. And I'm pretty sure most people know at this point that Rafiki Center, at least the adolescent clinic, is no longer in this building. We're in a different building, which is actually, it's not so bad. And I think that Dr. Apandi and the Rafiki team are still trying to provide some reproductive health services, but that might have changed actually with COVID and the change of buildings and so on. So as I mentioned, I am not going to talk really about Lonnie's work, Dr. Embleton's work. This is the cover from her curriculum that she adapted together with a group of street youth. And so it makes it very nice graphics. So I thought I would include it here. And I'm looking forward to the day that Dr. Embleton comes and presents this. So I'm just going to move on to EAT, or the Enabling Adherence to Treatment study. So what we learned over time is that the major challenges to street youth adherence to ART, for example, was that they don't have food to take their medicines with, and they don't have anywhere to really safely store the medicines. And because their pockets are regularly searched on the street, either by other street youth or by police. They get wet regularly. It's not easy to carry meds with you in your pocket if you're trying to store a bottle. And anyone who's trying to take these medicines on a regular basis can tell you that for the most part, you need regular food to take them with, or else the side effects are much worse. So we decided to try offering a modified directly observed therapy, or MDOT program, for HIV or other conditions. So we included PrEP, tuberculosis prevention or treatment, antibiotics, basically anything that required a high level of adherence. And we offered it in combination with a meal and on the background of peer navigation services. All right, so what happened was that somebody would come, they would go and get their prescription from the doctor and their medicines from the pharmacy, and they would bring those to us. And we had a farm tech working in the street youth module of Rafiki, and they would come. Sometimes it was daily, sometimes it depended on the participant, but for some of them it was daily, some of them it was semi-weekly. Some of them it was weekly, you know, because it's easier to carry only 7 pills as opposed to a whole bottle. And they would come, they would take their meds, they would have a meal that Eldostream, I think, and somebody else provided. It's really simple, right? Rice and beans or ugali and vegetable or whatever. And then they go. And, you know, I mean, for me, I was like, okay, well, let's try this. Mostly I want to see if it causes complete chaos. And it actually didn't. I think it was a little overwhelming for some people at the beginning, the Rafiki Center staff, because there were more street youth around more regularly. But it was really wonderful to witness how, you know, they kind of integrated with the Rafiki clinic in general over time. And so we used a single group kind of pre-post test design, enrolling a convenient sample of self-identified street-involved individuals of any age. We didn't want to restrict it because there are a lot of parent-child, you know, dyads basically on the street, or families on the street, and we wanted to take a more kind of family approach if that was the situation. And so we did this between July 2018 and February 2020. And in that time, we enrolled 87 participants, of whom 53% were female. And 53% of them were aged less than 30, and 86% of them were living with HIV. Of those, at baseline, 75% had ever initiated HIV, ART, and 59% were active in care. So, you know, there was still a lot of room for improvement there. And by the end of the follow-up, all participants living with HIV had initiated ART. Almost 90% of them were active in care. 77% of them had had a viral load test, and 59% of them were virally suppressed at their last viral load measure. So, you know, this is a small, convenient sample, so it's hard to draw any firm conclusions. But you know, it was pretty affordable at about $68.23 per participant per 30-day period, and there are a lot of ways to cut down the costs for that. You know, the meals were less than 100 bob a day, and we really concluded that trials of this kind of study powered to detect statistically significant changes in HIV outcomes are really warranted, because this is the kind of structural intervention that can really enable a population such as street-involved youth to take their ART, right, on a regular basis. So just coming back to this, we're going to go now to the implementation, scaling up effective policies and programs. I'm going to talk about this grant that we got from the Canadian Institutes of Health Research. It's a component to HIV implementation science grant, and the project is called the Peer Navigation Project, or PNP. And it's all about adapting and scaling up peer navigators to increase uptake of HIV prevention testing and treatment among street-involved and homeless youth in Canada and Kenya. And we have 3 sites in Canada: London, Ontario, Montreal, and Toronto, and 3 sites in Kenya, so Eldoret, Huruma, and Kitale. In all the sites, where our target population are homeless and underhoused youth aged less than 30. And in Montreal and Toronto, our target population are specifically those who are lesbian, gay, bisexual, queer, transgendered, and two-spirited, which are indigenous gay and lesbian transgender people, okay? And the grant is for 5 years, so we are going until the end of 2023. And phase 1, the first part of it, which basically ended early this year, I think we could say. We basically investigated barriers and facilitators of accessing HIV services for street youth, acceptability of peer navigators, adaptations needed of the intervention in each site according to street youth, healthcare providers, and community stakeholders. And so we used predominantly qualitative methods, but we also did some quantitative assessments around like what components should ideally be included in a peer navigation model. And then the second phase of the study is all about the implementation and scale up. And so we're into that now. So just to briefly show you, this paper will be under review, I think, within the next couple of weeks. We tried to investigate barriers and facilitators of accessing HIV services. And we used the socio-ecological framework to understand them. And so we found, for example, things like intersectional stigma and discrimination, which we put at the social level, but which really is pervasive across all of these, right down to the intrapersonal. But things like inadequate access to basic needs, lack of health insurance, limited community-based funding, or in the case of Eldoret, almost no community-based funding for services for street youth. And things like inadequate HIV educational outreach and so on, difficulties communicating with service providers, those were challenges, lack of trust and so on, low self-esteem, those were all barriers. But then on the flip side, there were a whole bunch of facilitators that really spoke to things like systems navigation support could make a big difference. Personal relationships, peer support could make big differences. And, of course, education and awareness and so on. So, for us, this basically says, okay, well, the peer navigation model is potentially a really great intervention to help engage this population. So to date, okay, since I guess March or April, the Kenyan sites have enrolled 521 participants so far, including 221 females. There have been close to 200 follow-up encounters over time. They're kind of equally distributed, 26% sleep on the street. And it turns out the shared shelter and the rented house apartment are actually overlapping categories, okay, at least in the case of Kenya, and usually very short term. And they do it in groups, okay? So they'll all cram into one room, for example, and they'll call that a rented apartment or something. 68% of the population's already previously been tested for HIV, which I take to be a real sign of success of the peer navigators previously and the point in time count and so on, of whom 15% were HIV positive, are HIV positive, and the vast majority of them are in care, which is, again, fantastic. About 60% of the rest are willing to test, and about 2% are HIV positive. We've been having a really hard time getting HIV test kits, either the rapid test kits or the self-test kits. And so there's not been as much testing going on as really needs to happen. We also identified at enrollment 26 women who were pregnant, of whom 21 or 81% had attended ANC at least once. So this is something, of course, that's related to HIV prevention of mother-to-child transmission, and is very, very important for a whole bunch of reasons. In the Canadian sites, the Toronto site hired their PN in February, and it worked really well, except that for a variety of reasons, the peer navigator wasn't able to enroll any participants. So we have no data from Toronto at this stage. That peer navigator actually was inspired, and she's gone back to university to finish her education. So that's very exciting. And we're hiring someone else. And so the Canadian sites, especially among the LGBTQ community, there's research fatigue. There's a lot of suspicion of researchers. It's kind of complicated. The peer navigator in London was hired in May and has been working well. And at last check, we had 3 participants enrolled, although that was a couple of weeks ago. In Montreal, the hiring is still pending. It's probably the most challenging of the 3 sites in Canada, in part because in Canada, HIV is basically criminalized. So if you, for example, have HIV, are not on ART, and have a detectable viral load, technically, you can be reported to the public health authorities, and technically you can be taken to court and fined and sent to jail. And so, you know, the LGBTQ community in Montreal, they're like really reluctant to participate. And this didn't come up actually in the phase 1 work, but as it turned out, has become like a really major obstacle to engaging street youth with peer navigators in this context. So our next steps are to try to scale up peer navigators and elsewhere in East Africa and Canada, to layer on community facility-based adherence supports. And I think most importantly, to try and test adaptive multi-component interventions to find, link, treat, and retain street youth living with HIV, and to prevent infection in those at highest risk. Okay, so that's, at least in my virtual world, that's the plan. So I'm just going to leave you with a few discussion points, things to think about. So clearly there are a lot of evidence-based interventions that exist that can really effectively engage street-involved children and youth if they're adequately adapted to the unique circumstances of the population. So the question is, what will it take to get USAID PEPFAR to fund them at scale? Peer navigators, VMMC. I mean, these are, you know, adherence supports for this population. There are a whole bunch of things that really we could be doing a lot better if we had some more funding to scale them up. But what are the optimal combinations of strategies to engage this high risk and hard to reach population, especially in low income settings, and especially where intersectional stigma is a major barrier to accessing healthcare? All right, how do we do this in a way that doesn't further stigmatize or drive them further into the margins? And how do you build healthcare services in the absence of community services without overwhelming healthcare settings and providers? A lot of the things that happen in the healthcare setting for street youth, they could really be happening in a community setting, except those community settings don't really exist. You know, community clinics, outreach clinics, those kinds of things. And so, you know, there's not a lot of balance really to be able to do that. So I really just want to end with thanking CIHR, the IDRC in Canada, NICHD, and all of the investigators and staff and street youth community leaders and so on, who have, the Rafiki Clinic staff, the Wazingishu County Children's Office, you know, they've all been really instrumental to making this all happen. So with that, I will stop and we'll be happy to answer any questions you have. I see Dean Nangami here has a question: what knowledge and or skills are given during isolation to those who undergo the VMMC? Well, there was a whole curriculum developed, and it was developed actually by people like Professor Emily Choge and community stakeholders, Professor Ayuku, Professor Eunice Kamara, you know, a really diverse group of academics and community experts who, you know, who built on like ICIPE. I don't know if you know ICIPE. This is a VMMC curriculum that was developed, like an alternative kind of coming of age curriculum for boys that I think Professor Choge developed with some others and used to offer it pretty regularly, but it very Christian based. And so they basically, and Joyce Niero, she was also involved, and they spent months actually developing this this curriculum that included life skills and HIV prevention education and attitudes around gender and violence and all that kind of thing. It was really pretty comprehensive, actually. Any other questions? Dean Nangami, you are on mute.
Yeah, can I follow up on that question?
Yes, please. Sure.
Did the team include someone from social services or children's department, someone who could help with the rehab and integration And also, when you talk of life skills, I would expect there are lots of challenges on the streets, things like first aid, basic things to equip the young people. Thank you.
Yeah. Well, certainly the county children's officer or district children's officer, whatever he was at the time, was very involved, and came and spoke at the graduation and was definitely kind of a part of the process. I don't think anybody from social services actually delivered the curriculum. The people who delivered the curriculum, I see Mark Amolo is on the line actually, and Professor Ayuku and Eunice. I don't actually clearly remember who delivered it, but I seem to remember it was a number of the community leaders. David, do you remember who actually delivered it?
Yes, and some of the former street children or older street children, and Dominic, who is our social worker. And of course, sometimes Alan could chip in, the late Alan, commander.
Right. And as far as life skills, I think they were a little more basic. I don't think they included first aid.
Yeah, they were just basic life skills. We just borrowed from the schools. What they do is life skills.
Now, there were a bunch of boys who actually, by the end of it, really wanted to go home. And so we facilitated that, actually. We paid for them to travel, and to get reintegrated into their families, without a lot of counseling and stuff like that. But that definitely happened. As I recall, there was one kid, though, one boy, whose mother showed up to take him home, and he absolutely refused to go. And he went into really a kind of post-traumatic crisis. I couldn't put it any other way. And so, although she really wanted to take him home, the kid really refused. And so at that point, we engaged Dominic and Beruham, who I think at the time were called Berur, which is a children's home basically for street-connected women and their children. And all agreed basically that the boy could go to Berur for a while. I think he eventually came back to the street, but he categorically refused to go home and was in such crisis at the thought of going back home, that we all agreed that it was not the ethical thing to do to force them to go. So, yeah. So it was good in that sense, it had some happy endings. I don't know if they stayed at home or got back into school or whatever, but I'd like to think a couple of them did at least. The question is to establish, this is again from Dean Nangami, how many prefer to leave the street and opt to go home or to a formal rehab center? Well, probably most of them, if they had a decent option to go to, right? So the problem is that there aren't a lot of alternatives. And a lot of these kids are leaving their home because of extreme poverty, child abuse, and family conflict. So the first question is, well, have those circumstances changed? Is there enough to eat at home? Are there school fees and school uniform to send the kid to school? Are they going to get beaten? Do they have an evil stepmother? Do they have an evil stepfather? Those are the basics. Just because a kid has technically parents or a home doesn't mean that that is a safe or supportive environment for them to be in. And unfortunately, in terms of formal rehab center, the only formal rehab center that exists, for example, in Eldoret is Tumaini. And, it can accommodate a relatively small number of boys, although I know they're thinking about trying to expand to girls and to increase the numbers. But, there's also the rescue center, which has been there, at various levels of function over the years. But there's really not a lot. This is part of the problem. Without community supports and without a social safety net and structural interventions like expanding the cash transfer program, for example, those are some of the things that could make a really big difference if they were in place, but they're not. And so this is the real challenge, because, you can't, it's not like there are a ton of alternatives for these kids. So a public health perspective is like, okay, well, let's meet them where they're at, right? And try and engage them where they're at and reduce the risks of living on the street, so that when they are able and willing to get off the street, at least they're not taking HIV with them now, in addition to everything else that they've gone through. So Mabel Dinagami says, can we consider including those who willfully consider a change under the MCF project? Link them. Yes, absolutely. That's a fantastic idea. So I love the idea, Dinagami. Let me know how I can help. I think it's terrific. And I think Tumaini Center, the Tumaini Innovation Center, and Professor Ayuku specifically, can really strongly engage on that kind of thing, because they're trying to do some innovative things with skills development and so on. So yeah, we can talk about that further. Jerry Wagner, WI WIP sign-up sheet. Okay, I think we're being asked to sign the sign-up sheet just to show that we were all here. Okay, so maybe note to self for all of you, please do that.
Yeah, not this, for the participants, but well, actually for participants, but if they would like to sign up to give a presentation.
Oh, what a
work
great
in progress
idea.
in the future. Hey, how about that?
What a great
Yeah.
idea.
Yeah.
So Dean Nangami, Dr. Baluku, I'm seeing quite a few of you on here. I think Leslie, you've presented in the past. Dr. Kamau, yeah, there's many of you. You have lots to share.
Thanks.
All
I
right.
thought it was a list of participants, only to realize it's for presentation.
Well, I hope you signed up.
I think it needs a bit of reflection on what, and not like just jump onto it. So
okay.
If it's okay, we can sign up and send it in. Yeah, thank you.
Okay, great. All right. So we are past the top of the hour here. So I think, let me just say, asante sana. Thank you for joining and listening to me today, and look forward to connecting with many of you in the coming weeks and months. Okay. Jerry, Chiri, any other announcements?
None for me. Just that we'd encourage people to sign up for the next WIP, and the next WIP would be in October, same time, last Monday. Cheering, anything else?
None from me either, but I wanted to say thank you, Paula, for taking us through this work in progress. We've learned a lot over the 10-year process or more, actually, from what you've done with the street youth and street children. And we really appreciate it. Thank you so much.
Karibuni.
Yeah, well said.
All right.
Well said.
Bye, everyone.
All right, take care.